imagine your body's internal alarm system goes off.
Right.
Right. Just blaring at full volume, warning you of this intense, overwhelming physical arousal.
Oh, wow. Yeah, that sounds intense.
It is. But here's the catch.
Yeah.
There's absolutely zero desire attached to it. The alarm won't stop ringing for hours or, maybe even days or weeks.
Right, which is just completely exhausting.
Exactly. It's exhausting, it's painful, and it is entirely mechanical. Now, imagine someone suggesting you treat that agonizing misfire by taking a biological stimulant and injecting it directly into the nerve center.
Oh, man. Yeah, that's a lot to process.
It really is. Well, welcome to the Deep Dive. We're thrilled you could join us today because our mission comes straight from a listener who reached out with incredibly specific, a really fascinating question. They asked, can the O-shot help with PGAD?
Right. And PGAD stands for Persistent Genital Arousal Disorder. And I have to say, it is a phenomenal question.
It really is.
Because answering it requires us to navigate this really murky space where aggressively marketed wellness trends collide with these deeply misunderstood, highly severe neurological conditions.
Yeah, it's wild.
It's basically a masterclass in why we have to separate biological mechanisms from, commercial hype.
Absolutely. So to get to the bottom of this for you, we've pulled together a pretty dense stack of sources today.
We really have.
We're looking at clinical trials from journals like Obstetrics and Gynecology, peer-reviewed scoping reviews, marketing materials from high-end medical spas, and some incredible insightful interviews with leading sexual medicine experts.
Specifically, Dr. Sue Goldstein and Dr. Robert Eschenberg.
Right. And we're going to distill all of this down so you have the clear, thorough knowledge you need without feeling totally overwhelmed by the medical jargon.
Yeah, the goal here is to really understand the why and how behind the medicine. We're dealing with sensory misinterpretation, essentially. Like, what happens when the brain and the pelvis stop communicating correctly, and how modern medicine tries to intervene.
Okay, let's unpack this. Because to evaluate if the O-shot actually treats PGAD, we first have to look at the cellular mechanics of what the O-shot is.
Right, the basics.
Exactly.
Yeah.
So we know it's a trademarked form of PRP therapy, which is platelet-rich plasma. And looking at the medical SMA materials, the procedure relies pretty heavily on specific centrifuge technologies, like the sulfal system.
Yeah, that's a common one.
So they draw your blood, they spin it down to isolate the plasma, and then they inject it back into the clitoris and the anterior vaginal wall. Oh, and this is after applying a heavy numbing cream, obviously.
Yes, very important detail. And the mechanical goal of that centrifuge process is to isolate the alpha granules within your platelets.
Okay, alpha granules.
Yeah. When you concentrate those and inject them into tissue, those granules release really high levels of VEGF. That's vascular endothelial growth factor.
That sounds like a mouthful.
It is. But VEGF is essentially the primary biological signal that triggers angiogenesis.
Angiogenesis meaning the creation of brand new blood vessels in that specific localized area, right? I like to think of this PRP mechanism as like a highly targeted biological fertilizer.
Oh, that's a good way to put it.
Right. You're taking the body's own localized growth factors and just flooding a specific region to wake up sleeping tissue, stimulate new vascular networks, and boost collagen production, all to increase physical sensitivity.
And that biological mechanism is exactly the foundation for the commercial claims. The inventor of the procedure, Dr. Charles Runels, and the various clinics that license the trademark, they advertise that this surge in localized blood flow treats a lot of things.
Like what, specifically?
Well, they claim it treats low libido, vaginal dryness, dyspareunia, which is painful sex, and even mild stress urinary incontinence.
Wow, that's a pretty long list.
It is, but the flagship promise, and the reason it's called the O-shot, is the facilitation of stronger, more frequent orgasms.
Which I have to point out comes with a pretty steep price tag. Depending on the clinic, it costs anywhere from $1,200 to $2,500 out of pocket.
Yeah, it is not cheap.
No. And it is crucial to note that it is not FDA approved for sexual dysfunction. But does it actually work? Or is this just expensive wishful thinking?
Well, that lack of FDA approval is fairly standard in the rapidly moving field of regenerative medicine, to be fair. It doesn't inherently mean it's ineffective.
Right.
But it absolutely means the burden of proof rests heavily on independent clinical data. And I'll tell you, that data is fiercely debated.
Wait, I'm looking at the stack of research right now, and I see a recent randomized controlled trial by Clark and colleagues. This was published in the highly respected Green Journal of Obstetrics and Gynecology.
Yes, the Clark study.
Yeah, they ran the placebo controls, they tracked the metrics, and they found that women treated with PRP injections in the anterior vaginal wall actually demonstrated measurable improvement in sexual function scores.
They did find that, yes.
They recorded increased natural lubrication and better overall arousal. I mean, that sounds like genuine, peer-reviewed proof of the biological fertilizer concept.
On the surface, it does.
But then we look at the interview with Dr. Sue Goldstein from San Diego Sexual Medicine. She's one of the leading clinical experts in the world, and she is calling the O-shot a total marketing gimmick.
Yeah, she does not hold back.
Not at all. So how can a peer-reviewed journal and a leading clinical expert look at the exact same biology and reach completely opposite conclusions?
Well, the discrepancy really comes down to anatomical specificity and also the business model behind the trademark.
Okay, break that down for me.
So Dr. Goldstein points out that while PRP might show some efficacy in the anterior vaginal wall, which, aligns with that Clark study, there is a glaring lack of clitoris-specific data.
Oh, I see.
Yeah, there's just no robust evidence proving that injecting concentrated VEGF specifically into the clitoris reliably alters orgasmic function. The biology might make theoretical sense, sure, but the clinical outcomes in practice just aren't reliably there yet for women.
Got it. And her criticism goes way beyond just the anatomy, right? It's also about how the treatment is franchised.
Precisely, because the O-shot is a patented trademarked term.
Right.
So providers who want to use that specific name for marketing, they must join a buyer organization. And in exchange for the branding and some discounted centrifuge equipment, they are often mandated to charge the patient a specific premium price.
So they have to charge that $1,200 to $2,500 fee.
Exactly. Dr. Goldstein's clinic actually utilizes PRP therapies as an experimental option, but they do it for a fraction of that trademarked cost.
Oh, wow.
And they are incredibly upfront about the highly variable success rates. She basically views the trademark as a mechanism to enforce premium pricing on unproven hope.
Okay, so the O-shot is effectively a biological megaphone. It uses vascular growth factors to try and turn up the volume on nerve endings and blood flow.
That's a great analogy.
But here's where it gets really interesting. If the O-shot is designed to be a megaphone for pelvic sensation, what happens when you hand that megaphone to a nervous system that is already screaming?
Which pivots us perfectly to the core of the listener's inquiry, PGAD, Persistent Genital Arousal Disorder, which is increasingly known in the medical literature as genitopelvic dysesthesia. It was first identified back in 2001 by researchers Leiblum and Nathan.
Okay.
And we really have to establish a rigid boundary right now regarding what this condition actually is, because it is widely and tragically misunderstood by the general public.
Right, it's not what it sounds like.
Exactly. A PGAD is not sexual disorder. It is not hypersexuality, and it has absolutely nothing to do with a high sex drive.
It is a severe pain disorder, a neuropathy. Going back to that analogy of the car alarm, the alarm is blaring at top volume, doing exactly what it was mechanically wired to do when triggered. But there is no one breaking into the car.
Right, the wiring is just misfiring.
Exactly. For someone with PGAD, the pelvic nerves are firing these relentless signals of physical arousal, but the brain is completely detached from it. There's zero psychological desire or interest.
It is an agonizing sensory misinterpretation, and the clinical literature is just full of harrowing patient accounts.
Yeah, reading through those was tough.
It really is. We are talking about intense throbbing, extreme pelvic congestion, unrelenting pressure, and basically feeling trapped on the absolute precipice of an orgasm.
And this isn't just a fleeting sensation either.
No, not at all. This physical crisis can lock in for hours, days, or even weeks continuously.
And the triggers are jarringly mundane, like things entirely divorced from anything sexual.
Yeah, completely everyday things.
Wearing stilettos can trigger a flare-up because the altered posture shifts the pelvic alignment and pinches a nerve.
Wow.
Or a bumpy car ride, a vibrating bus seat, even just sitting through a long office meeting with a full bladder pressing against the pelvic floor, they can set off this cascading neurological alarm.
To understand how something like a bumpy car ride can mimic sexual arousal, we have to look at the underlying mechanics of the pelvic nervous system.
Okay, lay it on me.
The medical texts point heavily to pudendal nerve entrapment. The pudendal nerve is the primary conduit for sensory information from the genitals to the brain. If that nerve gets physically compressed or irritated by surrounding muscles, ligaments, or fascia, the action potentials, which are the electrical signals it sends, they become chaotic.
So it's basically sending static.
Exactly. The brain receives this chaotic static, and it misinterprets it as intense genital engorgement.
Dr. Robert Aschenberg's interview highlights this beautifully, I think. He contextualizes PGAD not as an arousal issue, but as a specialized subset of chronic pelvic pain syndromes.
Yes, that distinction is so important.
The body is experiencing a pain response, but because of the specific nerve pathway involved, the brain translates that pain signal into an arousal sensation.
And, that translation error can originate further up the nervous system, too.
Oh, really?
Yeah. One of the most fascinating mechanical causes detailed in the literature is the presence of Tarlov cysts.
Karloff cysts, what are those?
They are perineural cysts. Essentially, they're fluid-filled sacs that form on the nerve roots at the base of the spine, specifically the sacral nerves like S2, S3, and S4.
And those specific sacral nerves happen to house the parasympathetic fibers responsible for genital reflexes.
Exactly. So when a Tarlov cyst swells and mechanically compresses those sacral nerve roots, it short-circuits the signal.
Oh, wow.
Yeah, the nerve begins firing action potential spontaneously without any input from the brain or the genitals themselves. The brain just receives this constant screaming signal from the sacral root and interprets it as unrelenting physical arousal.
That is wild. And then there's the pharmacological trigger, which I honestly found to be the biggest aha moment in this entire stack of research.
Oh, the SSRI connection.
Yes. The sources show that PGAD can actually be induced by the sudden withdrawal of SSRI antidepressants or medications like trazodone.
Yeah.
Let's spend a second on this because to me it sounds completely counterintuitive. How does stopping an antidepressant cause a pelvic nerve disorder?
Well, it comes down to neurochemistry and how the brain balances its inhibition systems. SSRIs increase the amount of serotonin active in the brain, and serotonin generally acts as an inhibitor to sexual arousal. It essentially puts the brakes on the dopamine and norepinephrine pathways that drive libido.
Right, which is why a lot of people on SSRIs experience low libido.
Exactly. So when a patient takes an SSRI for a long period, their nervous system adapts to having those brakes constantly applied.
So when they suddenly stop taking the medication,
The brakes are removed instantaneously.
oh man.
Yeah. The sudden, precipitous drop in serotonin leaves those genital arousal pathways completely uninhibited. The neurochemistry rebounds so violently that the nerves begin firing wildly, leading to this localized hypersensitivity.
So the body is literally going through a localized neurochemical withdrawal that manifests as PGAD.
That's exactly right.
That is incredible. And, whether it's caused by a medication withdrawal, a spinal cyst, or a high-tone pelvic floor dysfunction where the muscles are just chronically clenched in a spasm,
Yeah.
the psychological toll is absolutely devastating.
It truly is.
Because the physical symptoms masquerade as sexual arousal, patients are crushed by shame and embarrassment. They hide it from their partners, and worse, they hide it from their doctors.
The isolation is profound. Dr. Goldstein emphasizes that PGAD is arguably one of the most debilitating disease states in all of sexual medicine.
I can totally see why.
You have relentless physical discomfort compounded by intense social stigma. This combination leads to severe anxiety, profound depression, and a tragically high rate of suicidal ideation among patients.
It's just heartbreaking.
It is. And it is vital to recognize that while it creates immense psychological distress, it is fundamentally a mechanical neurological short circuit. It is not a mental illness.
So we have the O-shot on one side, a biological megaphone designed to use growth factors to upregulate blood flow and wake up nerve endings.
Right.
And on the other side, we have PGD, a condition where the nervous system is already screaming, locked in a hypersensitized state of sensory misinterpretation. So to finally answer our listener's specific question, would a patient suffering from the agony of PGD turn to the O-shot for relief?
Synthesizing the clinical data, the scoping reviews, and the expert testimonies, the answer is an unequivocal, definitive no.
Yeah, that makes sense.
There is zero clinical justification in the provided literature for using clitoral PRP or the O-shot as a treatment protocol for genitopelvic dysesthesia.
If the O-shot is all about increasing nerve sensitivity and blood flow, Wouldn't injecting that into a PGA patient be like throwing gasoline on a fire?
That is exactly what it would be like. It is the exact opposite of the required clinical intervention. The biological mechanisms are entirely adversarial here.
Right.
The OSHOT attempts to upregulate sensation. A patient with PGAD is trapped in a sensory crisis. Their medical treatment requires downregulating the nervous system. You have to quiet the nerves, not feed them growth factors.
So what does the actual PGAD toolkit look like then? Because looking at the medical texts, the real interventions are geared entirely towards silencing those signals.
It requires a highly specialized, multidisciplinary approach. Neurologically, specialists might use pudendal nerve blocks.
Okay, how does that work?
By injecting a local anesthetic directly into the nerve bundle, they can chemically interrupt the chaotic pain signals traveling to the brain. And in cases driven by high-tone pelvic floor dysfunction, they actually utilize targeted Botox injection.
Great, Botox, like for wrinkles.
The very same.
Uh,
But here, it paralyzes the spasming pelvic muscles, forcing them to physically release their grip on the entrapped pudendal nerve.
That is fascinating. And regarding the vascular side of things, where the OSHOT uses VEGF to try and build new blood vessels,
Yeah.
PGAD patients are actually instructed to do the complete reverse, right?
Yes. They utilize ice baths and cold compresses to heavily constrict the blood vessels.
Brr.
Yeah, not fun, but it forces the blood out of the pelvis to reduce that agonizing congested pressure.
The scoping reviews also mention physical interventions, like 10NS units. They attach electrodes to the skin that deliver these small, strategic electrical impulses.
Right, to disrupt the signal.
Exactly. The goal is to flood the local area with a different, non-painful sensory signal, which essentially distracts the brain and disrupts the misfiring PGAD alarm bells.
Are very clever.
It is. And pharmacologically, instead of stimulants, doctors prescribe anti-seizure medications. These drugs work by stabilizing the membranes of overactive nerves, preventing them from firing those spontaneous action potentials.
And we also have to look at the extreme treatment-resistant cases, too.
Right, when the gels and nerve blocks don't work.
Exactly. When numbing gels, physical therapy, cognitive behavioral therapy, and nerve stabilizers fail, the interventions become major medical procedures. Like, if the source is a Tarlov cyst, neurosurgeons will actually perform minimally invasive spine surgery to drain the cyst and relieve the physical compression on those sacral nerve roots.
The sources even detail the use of electroconvulsive therapy, or ECT, for the most severe cases of PGAD.
Yeah, which sounds incredibly intense.
It does, but the mechanics of why it works are fascinating. By inducing a highly controlled, generalized seizure under anesthesia, ECT causes a massive systemic release of neurotransmitters: serotonin, dopamine, GABA.
It acts as a hard reboot for the central nervous system.
Exactly. If the brain is stuck in a chronic neuropathy feedback loop, misinterpreting pelvic pain as arousal, that neurochemical reset can sometimes break the loop when nothing else will.
If we connect this to the bigger picture, when you lay the two toolkits side by side, the contrast is absolute. As Dr. Sue Goldstein summarizes, the OSHOT is marketed as a commercial wellness enhancement for anorgasmia and a lack of localized sensation.
Right.
PGAD, on the other hand, is an acute, severe medical crisis of hypersensitivity. Applying a regenerative treatment designed to cure numbness to a patient who is actively suffering from agonizing hypersensation. It just demonstrates a fundamental misunderstanding of the underlying pathology.
Which brings us to the core takeaway from this deep dive. The OSHOT is an intriguing, albeit highly debated, regenerative therapy that attempts to use vascular growth factors to enhance sensation. But it is definitively not a treatment for PGAD.
Not at all.
Persistent genital arousal disorder is a complex, agonizing neuropathy. It demands a sophisticated medical approach focused on down-regulating a short-circuited nervous system, whether through nerve blocks, muscle paralyzation, or complex neurochemical resets.
It requires targeted medicine, not a franchised wellness shop.
Exactly.
Recognizing that distinction is just so critical. It underscores why patients must look past the glossy medical spa brochures and dig into the actual cellular mechanics and clinical data of what they're putting into their bodies.
So what does this all mean? We've covered everything from alpha granules and vascular growth factors to spinal cysts and serotonin withdrawal today. But as we wrap up, there is one final concept from this stack of research that we want you to mull over.
Yeah, and it is a concept that fundamentally challenges our perception of human biology.
Lay it on us.
Well, we just spent this entire deep dive exploring how a mechanically trapped pudendal nerve, A fluid cyst on the spine or the withdrawal of a routine antidepressant can cause agonizing, unrelenting pain. Yet the human brain misinterprets and expresses that specific pain as intense sexual arousal.
It's crazy to think about.
It is. If our internal wiring can be so easily crossed, if the neurological pathways are so tangled that excruciating neuropathy perfectly masquerades as sexual desire, how much of our basic everyday understanding of human sexuality is actually just a misunderstanding of human neurology?
Oh, wow. It is a staggering thought. It highlights how unbelievably close the physical circuits for pleasure and pain are actually wired together in the brain.
Literally side by side.
It is just a fraction of a millimeter between a signal that brings joy and a signal that brings absolute devastation. And, it reminds us that sometimes the signals our bodies send us aren't telling us the truth. They are just structural errors in the machinery.
Beautifully said.
Thank you so much for joining us for this deep dive. Keep asking phenomenal questions. Keep analyzing the mechanics behind the medical marketing you see online. And we will catch you next time.